Right. Hello, everyone. Thank you for joining our May Pathways Community webinar. This is our second webinar of 2026, and we're so excited to feature voices across Africa of partners who've been using Pathways in lots of different and diverse ways. So we're excited to welcome four presentations and six speakers today that I think will really inspire you of the different ways that Pathways has been applied. Can we go to the next slide, please? So we have a new tool that we're using to support translation for this event. You should have gotten a ping in the chat to accept the Wordly. I can resend it again once the presentations get underway. But you just click accept, you open that. If you're not seeing it, you can look at the bottom of your Zoom screen where you have more and it has the three dots, and you should see Wordly there. It's fully integrated into the Zoom. So the way it works is you can choose your preferred language, and it is a live translation or for you to read in the language of your preference and follow along for the presentations. To toggle back and forth between that translation screen and the chat screen, you just hit chat and it'll take you to chat. And then if you want to go back to the app, you go back to those three dots and just select Wordly. So please drop in the chat if this is working for you, if it's not working for you. Part of this presentation will be in French. So we want to enable all listeners to understand fully the presentation, and we have several people joining who are Francophone, and this is for them to be able to hear the entirety of the presentation. So we're really excited to bring this. This is the first time we're using this feature in our webinars. Okay, we can go to the next slide, please. And this is our agenda for today. As I mentioned, we have four presentations that we're really excited for. First, we'll hear about segmentation that has been developed in Ethiopia in partnership with the Federal Ministry of Health. And then we will go to Nigeria and we'll hear about how segmentation has been applied through some work with the SWAP Coordinating Office to look at how demand for services can be increased. Okay, thanks, Badra. Then we will move to Senegal, where we will hear about data use in pathways. So we have a lot of data, but how are they actually using this to make decisions? And last but not least, we'll turn to Kenya and hear an exciting presentation about how Pathways is being used for adolescent girls and young women and a cash transfer program. There is a QR code on this slide. If you have not already, please click on this code and join the Pathways community. This will give you an opportunity to receive emails from us, which are just to let you know about events like this one and our newsletters, which tend to come out every other month. Next slide. So without further ado, we're going to turn to our presentation from Ethiopia, and let me introduce to you our speaker. Dr. Samson Gebremedhin is the principal investigator for the Pathways for Ethiopia project, which is being implemented by Project Hope. He is also a professor of public health nutrition at the School of Public Health at Addis Ababa University. So Dr. Samson, we're pleased to turn it over to you. And just let us know when you want us to proceed in the slides. Thank you.
Thank you, Amanda, for the kind introduction. So let's proceed to the next slide. We have been using the Pathways population segmentation approach to effectively reach vulnerable women in Ethiopia since 2024. So I'll be presenting specifically what we have been working over the last 2 years in Ethiopia. Next slide, please. So for those of you who have a kind of little understanding regarding the background information about Ethiopia, The Ethiopian primary health care, specifically the health extension program, had been very successful in terms of reducing maternal and child mortality by more than 70% over the last 25 years. However, one major increasing or emerging problem is inequality in reproductive, maternal, newborn, child health and nutrition outcomes, which is well documented in the literature. So the pathways approach can help to address this inequality in terms of identifying who is most vulnerable and in terms of designing precision public health informed interventions. Next slide. So uh, health inequality can be defined using multiple ways. Usually we use singular measures of inequality like wealth-based inequality or social inequality, geographic inequality, and the like to measure inequality. But in reality, inequality is caused by kind of intersection of all these factors. So rather than measuring specific or singular type of inequality, measuring compounded inequality like that of the pathways approach is recommended. So in the recent pathway survey that we recently completed, we observed that compounded inequality, which is measured based on the segmentation approach, is superior in terms of identifying health inequalities as compared to these singular types of inequality measures. Next slide, please. Next slide. So when we start implementing this project back in early 2024, the objectives we had, the first one was to identify source of vulnerabilities, be it social, cultural, economic, behavioral, and environmental vulnerabilities. And we achieved this by having a national qualitative study, by doing a systematic review of published literature, and also analyzing the existing DHS data. So once we identified context-specific source of vulnerabilities, we measure those vulnerabilities into national surveys, one among women of reproductive age and the other one among adolescent girls. So we use that data, we call them the pathways survey data sets, which were completed recently in late 2025 to develop our segmentation solution. So right now, we are at the early stage of developing segmentation solution informed interventions. So in addition to these three objectives, we also have an objective related to building the modeling capacity within the Ethiopian health system, including trainings on the pathways method. Next slide, please. So recently we completed our segmentation analysis and we developed separate segmentation solutions for urban and rural and also for women of reproductive age and adolescent girls. Specifically in this presentation, I will focus on the segmentation solution for women of reproductive age. So I'll not go through these near 40 variables that we used to do the segmentation analysis, but what I want to emphasize is the six major pathways vulnerability domains were represented in those vulnerability variables. And some of the variables are kind of typical variables which are measured in the HS surveys, and others like gender norms, health belief models, and different metrics of social support are new measures which are not measured in the HS. So initially we started with nearly 400 variables or vulnerability variables, but through a process of iterative data reduction, we ended up with these 40 variables for developing our segmentation solution. Next slide, please. So the most optimal population segmentation that we develop for urban and rural Ethiopia, considering both statistical fitness and robustness and also practical considerations, is a 5-class solution for rural Ethiopia, which has from most at risk to less at risk, of which some 9% is in the most at risk category, and the 4-class solution for urban Ethiopia. Once again, as indicated in the rate, something 14% of that population fall into the most at risk category. Next slide. So we used nearly 60% outcome, RMSHN outcome variables to rate, to rank these population segments, five for rural and for urban area. But just to present one of them, the most important one, child mortality. For example, in rural Ethiopia, we observe that child mortality ranges from 30 to 75 per 1,000 live births across the five segments with clear dose effect relationship. And in urban Ethiopia, the value ranges from 7 to 52. Uh, Once again, with more or less a very peculiar, clear dose effect relationship. So this shows, for example, if a health extension worker or a frontline health worker could be able to screen mothers at ANC entry point, uh, the pathways method would empower them to identify who would be having a risk of 7 per thousand child mortality and 75 per thousand child mortality. Next slide, please. So, as I have already indicated, the ranking of these population segments was done based on several variables, not only child mortality. For example, if you see in rural population segments, there was clear uh, differences across the segments in terms of the continuum of care, starting from contraceptive prevalence to skilled birth attendance and postnatal care, vaccination coverage, nutritional status, and care seeking for children. So this witnesses the strong discriminatory power of the population segmentation analysis, not only based on one or two indicators, but across some 60 plus outcome indicators. So this was an example of the rural population. In the next slide shows more or less similar pattern in the urban population. So the same pattern, dose effect relationship with minor noises across the key RMSHN outcomes that we measured in our study in urban Ethiopia as well. Next slide, please, Amanda. Yeah, so this is the how the five segments, for example, ranging from most at risk to least at risk, are geographically distributed across the 12 major regions of Ethiopia. So as you can see, the dark green, which represents the most at-risk population, which contributes nearly 8.5 or 9% of the population. If we see in Eastern Ethiopia, nearly 75% in Somali region or 50% in Afar region are in the most at-risk categories. And if you see the major regions like that of Tigray and Amara, the contribution of this most at-risk is relatively lower, showing the segments are systematically, not randomly distributed across these geographic areas, which is very compatible with the understanding that these two eastern regions are at higher risk of poor RMSHN outcomes. Next slide, please. We recently completed the development of typing tools. So typing tools are digital simple tools which enable frontline health workers to identify to which specific group a woman or a household belongs. So it is a tool that empowers frontline health workers because it enables them which specific group an individual belongs so that they could be able to provide tailored intervention. So the minimum threshold that we said was to have minimum of 80% sensitivity and specificity, and across the five rural and four urban categories, more or less, at least in 8 of them, we have successfully achieved this minimum threshold. Next slide, please. So before I conclude, I just want to say something about what we kind of lessons that we learned or best practices that we had in Ethiopia. So the recent Ethiopian Demographic and Health Survey was conducted just a year back. And one of the unexpected findings that we had was, despite the fact that urban fertility had been declining between 2000 and 2016, from nearly 3 to 2.4 total fertility rate, very recently it has increased back to level of 3.2, which was more or less the values that we used to have 25 years back. So the Ministry of Health tasked us to explain this recent increase in urban fertility and develop tailored intervention using the pathways method. And the analysis indicated the most at-risk segment of the urban population has almost 2 times higher higher number of live births, ever live births, than that of the three segments. The pattern more or less the same if we see the live births in the last 5 years. So we also conducted a kind of a deep dive analysis of their profile, and we observed that the most at-risk segment has very low family planning use, limited access to mass media and health information. Most of them are rural to urban migrants, and most of them they were living in small towns and peri-urban areas. In terms of economic status, they were also poor. But one positive finding we had was they had at least 80% of them had at least one antenatal care coverage. So we use that to propose tailored intervention by which the antenatal care service would be considered as a key entry point to provide postpartum family planning service for this most at-risk segment of the population. Next slide, please. What from the last 2 years engagement in population segmentation analysis in Ethiopia, what we learned is this vulnerability-based segmentation analysis is very superior to any kind of individual variable-based inequality analysis, be it urban to rural or socioeconomic factors or Wales index-based inequality analysis. And it also demonstrates very strong discriminatory power for multiple RMSHN outcomes, including child mortality. The typing tool that we develop has also very high sensitivity and specificity, indicating that it can be used for program implementers, including the Ministry of Health, to identify individuals or to allocate individuals according to their respective segments. So in terms of the project progress, our next phase is to use human-centered design to develop targeted intervention, which are segment specific and which are intended to provide precision public and informed intervention. And thank you very much.
Thank you so much, Dr. Sampson, for such a rich presentation and walking through the steps, sharing with us how those insights are informing different decisions and approaches for family planning and RNMCH interventions, and also just really emphasizing the power of segmentation and how you can learn so much about different audiences and their specific needs. So excellent presentation. If anyone has questions for Dr. Sampson, please add them in the chat. We will have a Q&A following our presentation. So for any of our presenters, drop those questions in the chat, or you can come off mute during the Q&A and ask the presenters yourself. So we're going to move along to our next presentation, which is going to focus on Nigeria. And I'll first introduce our speakers. So Dr. Dayo Adeyanju is a public health physician and health system strengthening expert currently serving as the national lead and coordinator of Nigeria's Maternal and Neonatal Mortality Reduction Innovation Initiative. That's MAMI. In this role, he specializes in designing scalable policies and primary healthcare strategies aimed at reducing maternal and newborn mortality across Nigeria. Dr. Dayo's technical expertise is rooted in a proven track record of implementing transformative health initiatives and coordinating national projects to expand access to quality care. Joining him is Liza McGang, who's a health specialist at the World Bank's Health, Nutrition, and Population Global Engagement Unit. Her portfolio focuses on advancing equitable access to essential health services and using applied systems thinking to surface underlying barriers to more effective service delivery. So Liza, I believe you'll be kicking it off. We'll let you take it from here.
Thanks, Amanda, and thanks to the Pathways team for organizing this event. It's really great to hear and learn from different countries that have been utilizing Pathways. And good morning, good afternoon, good evening, everyone. Maybe next slide, please. What I'll do is maybe just take a couple of quick minutes to set the scene and kind of give the broader context in which The World Bank and the government of Nigeria have come together to really leverage the rich data and insights that Pathways provides. And then I'll turn it over to my colleague, Dr. Dio, to really speak to a lot of the details of the engagement and how we use Pathways. But maybe just very quickly, last year at the World Bank Spring Meetings, a new target was set with a very clear health ambition to reach 1.5 billion people with quality, affordable health services by 2030. And that goal is not only about reaching more people in absolute numbers, it's really about reaching people who are currently left out of healthcare, and doing so in more places across more demographic and health needs while reducing the financial burden on households. And so in this context, primary health care really becomes the driver, the critical platform to achieve this. It's where prevention, basic treatment, maternal and child health, immunization, and referral all come together, connecting communities to the health system at various levels. Yet in many settings, and Nigeria is not unique in this sense, primary health care remains one of the weakest links and also the greatest opportunity for transformation. Next slide, please. And so, as I mentioned, Nigeria then becomes a very concrete use case for the 1.5 billion target, and has really challenged us to ask not only who is not being reached, but also why. And that's where the Pathways work has really been critical in surfacing some of those underlying barriers to care and access. For many women, the answer, though, is stark. There's no meaningful access to health care and to maternal and newborn care. And for many children, it means being zero dose or not having even the most basic immunizations. And so these are really not only coverage gaps, they are coverage gaps, but they're also signals that the system is failing. It's failing to connect families at moments when care matters most and can have the greatest impact. We won't go into the nitty-gritty of the data on this slides. I realize they're a bit busy. But to just summarize here, the inequities in access and utilization in the case of Nigeria, focusing on maternal health and immunization. In these graphs, it varies dramatically by level of wealth, by religion and ethnicity, as well as age and female empowerment. And so, put simply, a one-size-fits-all approach to expanding access and utilization will not work. The challenge is not only to increase services, but to design services that actually reach women, children, and communities who are currently outside of the system in ways that are convenient, appropriate, and really tailored to the value systems of these subpopulations. Next slide, please. And so that's where Hope PHC comes in. Hope PHC is a relatively new World Bank operation approved in 2024 for $1.57 billion, of which 570 million is allocated specifically to primary health care. So this is really what we call a full sector approach to increasing and improving human capital. And we're using the primary healthcare component of that project as the entry point to improving access, reach, and utilization of essential health services. Hope PHC focuses on reaching 40 million vulnerable people, especially women. And the focus is to improve the quality and use of essential reproductive, maternal, newborn, child, and adolescent health and nutrition services. So really an intentional investment in Nigeria's human capital. And then double clicking on Hope PHC, we have the Maternal and Neonatal Mortality Reduction Innovation Initiative, MAMI, which my colleague Dr. Dio on the line leads, and we'll go into in many more details. But MAMI is aimed at addressing and really crashing maternal and neonatal mortality, targeting 172 LGAs across 33 states with a focus on free, quality maternal and newborn care. And where we came to this agenda together was really thinking about some of the work that had been done to date on MAMI focused on the facilities, And so while you can have the most state-of-the-art facilities that are well equipped and connected, you can have the best transportation to get mothers and children there. If there's a perception of poor quality or a lack of trust in the health system, even the best health facilities will not necessarily improve your health outcomes. And so our approach was really to focus upstream and really understand and dig into those demand side aspects of why women and children are not receiving the care that is so critical for those key stages of life. And so with that in mind, that's really where our collaboration with the Mommy team started last year, using Pathways as a really critical tool to help dig into some of those tough questions. So I'll turn it over to Dr. Dio, who will now take us through in a bit more detail on our implementation and use of Mommy for designing for demand. Thanks, Dr. Dio. Over to you.
Okay, so thank you, Lisa. This is super good. It's good to be here. As I give some quick update on this work. So thank you also for inviting me, Amanda, and all the entire team for the Pathway and the organizers of this webinar. So straight, you've heard it from Lisa how we're trying to strengthen the system. Renewal initiative, we have declare health sector strategy blueprint, and one of which has 4 pillars. One is to improve governance, and then remove fragmentation. Second is to improve the population outcome, which is basically improve quality of care. And that means, the women and the children, where mommy sits. And thirdly is to improve local production of commodities, including MNC commodities and health security. And also coming into mommy, you heard when Lisa said maternal mortality is super high, 512 per 100,000, and neonatal mortality is also high. And it is high because of the 5 delays, that we have here. One is delay, in seeking healthcare, which is the major one that we'll be discussing here in terms of demand creation. Second is the delay in reaching healthcare, delay in receiving healthcare, and then, of course, delay in taking responsibility and accountability, which has to do a lot with data and mandatory reporting of maternal death. And lastly is the delay in coordination. So like you heard, these we have identified 172 LGAs, contributing to high maternal mortality across 33 states. And so we actually have gone to all of these LGA, to co-create with the community, with the local government, with the world, the state, what is called the MAMI, implementation plan. And then set up a structure, what we call the MAMI State Task Force, to implement this plan. And it is in this plan, clearly we define the MAMI strategy framework, which is the next slide, actually, which includes one, if you can give, yeah. So this slide includes one, community engagement, to be able to reduce the delay in seeking healthcare. So also is the emergency transportation to counter delay in reaching healthcare. Facility readiness to improve that delay in receiving healthcare, which includes one, to be able to have a facility that is BMONC that is level 2 functional, CMONC that is that is also able to perform beyond the 9th signal function test. It is also important, to say commodities and all the likes are there. Then importantly is the data, intelligence, surveillance, and all of that, to ensure that there's a mandatory reporting of every maternal death so we can forestall the future of that. And secondly, to improve our data quality. And also providing enablers, including incentives, to get to even create demand. And also deploy technology to be able to coordinate, all of this work. And a sector-wide approach, like I said, from the world through to this LGA, the state and the national, a coordinating mechanism. What is new now is the fact that we are able to have a sector-wide approach, which is the engine and the hub for implementing our Nigerian health sector strategic investment renewal initiative. It means that we cannot operate all of our intervention in silos. It has to be complemented or integrated in such a way that if the woman is linked to facility, the facility must be ready. If she's being evacuated, she must be going to a facility CMONC that is able to perform, emergency obstetric and newborn care. So with all of this in mind, and with the co-creation that we had at the state level, we came up with a plan. And I'd love to show you some of the things around demand, which is actually the next slide. So you could see across the state, you will be hearing things like, a pregnant woman in Imo State saying that, how can I think about going to the hospital when I can't even afford the transportation? And a lot of the patients actually go to traditional birth attendant. And some, will go ahead and tell you, I can't even make a decision to go to the clinic myself, must wait for my husband for permission. So all of these are things we found when we went to do the deep dive and we did the co-creation. And so with all of this, we came back to begin to propose solution. And coincidentally, as we concluded, wrap up the co-creation, the pathway came towards the end of the last quarter, towards the end of last year. And they now help us subject, this in addition to further analysis using the vulnerable and then the vulnerable segmentation. And I think that's the next slide. So we had yes. So, this is just to basically say that what Mammy entirely is looking at is all the pathway, towards, getting the women in their journey to delivery, right from antenatal, to delivery. So importantly, the next slide, is what I want to mention, where we now had a pathway demand creation workshop, that looked at the different implementation plan that we had, particularly in 5 northern states, and that in that 5 northern states, we were able to subject what we found in terms of barrier leading to maternal death, in terms of the community engagement into segmentation, looking at their vulnerabilities and the human angle piece of it. The first day was where we looked at the presentation of the people's voice and the methodology of the demand, the pathway. And then the second, day, which, you can go to the second day. Yeah, the second day, we now try to layer all of this together, the vulnerability, and the 5 states were able to come up, with a clear, plan. At least 3 things, that will improve or counter those demand, to having access to quality healthcare. Because as we begin to strengthen in the journey of improving or strengthening the system, one, community-based health worker being engaged, emergency transportation provided, there's upgrading of the CMONC facility and the BMONC facility, and then also we are also trying to strengthen our data architecture. You can do all of this, like Lisa said, without you still getting the results. But looking at how the women will not have access to this quality care that you have provided. So this bit, came up. The state has at least 3, most critical demand, creation plan that they would be attending to. And that's the next slide that you'll be seeing. So they then started, so between last around December And now, states like Kebbi State have been able to organize in part of their plan, organize a weekly mobile outreach program, collaborate with community leaders to support health education initiatives, and then sensitize communities on the benefit of another visit and then scale back attendance. And they've also developed and implemented some micro plan tailored towards the communities. This was what they said they will do. And of course, the Kaduna State also conducted biannual roundtable discussion, with communities involving approximately 160 religious and traditional rulers, and the basic information there was to promote the benefit of antenatal care, skill-based attendance, as well as postnatal care. And all of this they did for Bauchi, Borno, and Kano, which is the other 5 states. What they have done, is to create what is called the community support groups across 20 LGA and then 323 wards to drive sensitization and awareness on MNCH services. So all of these they have done. So it doesn't come without challenges. Of course, there's challenge, of funding, which we at the SWAP office is trying to see how we are able to, bridge that gap. And also, there are other challenges, which include difficulty in identifying, engaging the male champions, and then of course, the constraint. So with all of this, well, early outputs, from the state have shown that there have been some increase in ANC, then some increase in scale-based attendance, and of course, we are trying to watch how that translates to a drop in the maternal mortality and newborn mortality, which is our ultimate goal, to crush, maternal mortality. So I think, I will, go on. I will try, as much as possible to stop it there and then entertain questions. I want to thank you for the opportunity and for listening. Thank you, and over.
Thank you so much, Dr. Dio and Liza, for this excellent presentation. Really, really nice to see those quotes and then think about how Pathways has data that can help, come up with demand solutions and drive insights to come up with different solutions to respond to a lot of the things that those women are saying. So excellent job. Please continue to put your questions in the chat. I've seen several come through. I definitely encourage some interactive discussion in chat, and we'll have a Q&A at the end. So let's move on to Senegal. I'll introduce our speakers for our next presentation. Mariam Fall is a public health professional and senior behavioral designer at Ideas 42, where she applies behavioral science to strengthen global health programs across West Africa. With over a decade of experience spanning research, monitoring and evaluation, and program design, she has built deep expertise in reproductive health, family planning, and maternal and child health, working alongside organizations including the London School of Hygiene and Tropical Medicine, Marie Stopes International, and ONGA-RAS. She is also a proud laureate of the OWLA Women's Leadership Program, because Mariam is dedicated to advancing women's leadership and building research capacity across the African continent. Dr. Amadou Bouya Ndao is a medical doctor specializing in public health and a sociologist. He's currently the Directorate of Maternal and Child Health in Senegal within the Ministry of Health and Public Hygiene, where he serves as head of the Planning, Monitoring and Evaluation and Research Unit. He has over 20 years of experience in public health at the district and national level. His experience spans from planning to the implementation of health interventions and then to their monitoring and evaluation. He has also contributed to many strategic and implementation documents and been involved in several research projects, including Pathways. So welcome to you both. I will turn it over to you, Mariam, for the presentation.
Thank you, Amanda, for the kind introduction. I think it's wonderful to have so many of you here with us today, and I'm sure we all agree that those were excellent presentations from Dr. Dio, Liza, and Dr. Sampson. So Thank you for sharing the fantastic job conducted in your countries. And to continue on that thread, I will now be sharing with you the work that we at Ideas for Teacher have conducted here in Senegal. Slide, please. So my presentation is structured around 4 sessions. I'll start by giving you a big picture on the use of pathway data in Senegal. Then I'll walk you through the process we followed, the tools we developed with a little demo. And finally, the key takeaways I hope you will bring with you. It's fine. So the Pathways project in Senegal focused on family planning, and the segmentation data contributed in helping the Ministry of Health through the Directorate of Maternal and Child Health that I will be calling DSMO through this presentation to better understand the different behavioral profiles, the motivations, the barriers, and service use patterns among family planning users in Senegal. And based on those insights, they identified real opportunities to not only improve targeted decision-making, but also tailor family planning intervention and communication strategies. Now, what makes the work in Senegal particularly meaningful is that it's government-led. We received feedback from the regional directors of health who requested that the shift goes from the regional use of data to the district level use of data, district level being where implementation happens. Therefore, we did not create a parallel system. We integrated the work into the current system. And for that reason, 3 districts, 1 in the region of Matam and 2 in the region of Louga were selected by the MOH to pilot implementation. And the selection was based on different factors such as MCPR, MCPR and other factors such as the varieties of segments we have in the in those districts. And following assessment of the potential. Oh,
Miriam, do we need to advance any of the slides?
yeah, yes, I cannot
Yes.
see the slides weirdly enough. Okay, now I can. No, this was, I'm still on slide.
You're still here on the
No,
process.
no. The one before. The one before.
The one before
The
is
pathways data used in Senegal.
this one.
Yep,
Okay.
yeah.
Okay, I'm sorry. Okay.
Yeah, that's fine. So I was explaining that the piloting happened in 3 districts, including 1 in Matam and 2 in Louga. And the choice was made because of the MCPR rates in those districts, but also the variety of segments we had in those districts. And following the assessment of the broad potential use pathways use case that we have, the 4 broad ones, we decided to focus on the design phase, which is the district annual work planning, with the objective to identify the barriers to data use during the annual work planning, but also to co-design practical tools with end users. Slide. Okay. So to guide our work, we use Ideas for Teacher IDEAS framework, which is a behavioral science methodology. And as you can see, the I stands for identify the desired outcome, the D diagnose the context, the E engineer the behavioral solution, the A analyze the effectiveness, and the S scale. Now, for the purpose of this project, we just went through the first 3 phases of the methodology because of scope of work reason. And just to say, what I really like about this framework is the tagline that says, where empathy meets science, because that's exactly what we try to do. Understand exactly what is going on at district level before designing anything. Slide. So for the first phase, which is the identification of the desired outcome, we had a clear action in mind, which was the use of pathways data during the annual work planning of family planning activities. And we needed to understand the actors involved. It is important actually to frame the scope of the work as a behavioral problem to avoid making embedded assumptions about why the problem is, and to be able to design solutions that are data-driven. So we ended up with this problem statement that says district level officials do not use pathways data segmentation in the annual work planning for family planning activities. And based on that, we went to the next phase, which is the diagnose phase slide. So the diagnose of the context was through consultations with the district officials of those 3 districts to go over the process, understand exactly how they do the annual work planning, what are the different steps, who are the actors that are involved, and what role do they play. And from that consultation work, these 3 barriers were linked to the use of pathway segmentation data. The first one being that they did not consider using pathways data because they did not have cues in their day-to-day work. The second barrier was that they perceived that other sources that they are used to working with were more familiar, more reliable, and easier to use than pathways. And the last barrier was that although they might be interested in using pathways data, they did not know how to. So after identifying the desired outcome, we diagnosed the context to better understand, to go to the next step, which is the engineering slide. So to engineer the behavioral solution, we went through a rigorous process of what we call ideation. So together with Sander, we generated a total of 135 ideas. Now, it's important to say that you would have a lot of duplicates if you have different organizations doing ideation. So we had duplicates, and for considering reasons such as funding or scope of work, we narrowed it down to a short list of 11 ideas. Now, all the work has been a co-work. We shared a short list of those 11 ideas to the DSME for them to review it prior to developing the prototypes. So when they reviewed it, they provided feedback on what they thought was not possible at all to do, what they thought could be improved. So we took into account all of those feedback to come up with 9 prototypes. 2 of them were dropped on the way because the DSME told us that it was not possible to actually implement that. And those were related to integrating pathways data into the current DHIS2, which is the data platform that's used at national level. So following prototyping, we went on the field in Matam and Luga in those districts to user test the tools. During the user testing, the tools were presented to them with their objectives, what we are trying to do with the tools, how it could help them better take decisions based on the pathways data. And we had a first round in December in person before where we collected all their feedback, made the changes they needed, considered all recommendations, suggestions from the district officials before presenting a second round, including all their feedback virtually in February. Slide. Now, following that work, the tools were developed. So this was the process we went through to get to the tools. And now I will be sharing my screen to show you a little demo of the tools. Can you all see my screen?
Yes.
Okay. So the main 2 tools that were developed, again, as I said, we had 9 tools prototyped and user tested. But then for the scope of the work, we could just hand over 2 tools. Others were well developed at an advanced level, but were not handed over for the purpose of this work. These tools were very recently handed over to the Ministry of Health, who will be using it and provide feedback to us about how impactful it has been in their work. So the gamified scenario presents itself like this. It's an app. The link is available, and you can have it both in English and French. As most of you probably know, Senegal is a French-speaking country. So we had it developed in French and English, especially for the end users who speak French. So what you have is a tool with the link to the Pathways platform for broader broadcast and seeing all the data at national level. And we explain what pathway segmented data helps to do and what the tool actually helps them to do. The tool isn't a tool to be used every day or during every planning session. It's a training tool. It's a simulation tool designed to help them apply pathways data in real world district planning scenarios. So it's to help them build the muscles to think about the segments, the channels, the messages, the intervention, considering pathways data. And we have paired it with what we call the reference sheet. So the reference sheet is a summary of the district segment, the most predominant segments in the district. And it shows the pathways level data with the determinants. I'll show it all right now to you, but just to explain, it's we like to call it a summary of the situational analysis of the district. And by looking at the reference sheet, the district's officials, when practicing with the tool, could actually see what option fits better with their district. So I'll just quickly show you how it looks. So you have the first step, finding your reference sheet. These are the 3 districts we were doing the pilot with. If I take the first one, Canal, it takes you to the reference sheet that looks like this. As I said, it has 4 aspects of it: prioritization of segments, selection of the right activity, selection of the right channel, and the right message.
Miriam, I hate to interrupt you. We are getting bumped on time, so maybe we could do a kind of wrap the demo up.
Okay.
And to let everyone know, we will share a link to this tool in our follow-up to the webinar, so you'll be able to play around with it yourselves.
Perfect. So this is just quick reference sheet, and then if you go back to the app, you can practice applying segmentation data, choosing which aspect you want to have to practice with the scenarios. And this is what the scenarios look like. It's real life scenarios that they could face, and they have different options of answers. When they click on an option, we provide feedback on whether it could be a good choice or not to select that activity or that segment or that channel. And if you go to the next question, just to increase their knowledge and confidence, we ask them why they selected that answer so that they could see feedback on whether that was great and what to consider when taking decisions related to either the segment, the message, the activity, or the channel. So as Amanda said, we'll be sharing this with you so that you can have a proper look, and I'll be available if you have any questions.
Thank you, Miriam. I think for sake of time, we should go ahead and go to Dr. Bouya. Dr. Bouya, are you able to come online and share a few remarks?
Oui, bonjour, je vous entends. Vous m'entendez?
Oui, nous écoutons.
Je peux y aller en français?
Oui,
Can I speak French?
oui.
OK. Voilà, je vais être bref. Bonjour à tous et merci encore de me faire participer à cette réunion que je trouve très intéressante. C'est juste rappeler le choix et le contexte du Sénégal. Je pense que c'est important à savoir. Le choix du Sénégal n'est pas anodin parce que le Sénégal est un pays francophone, le seul pays francophone qui a été embarqué dans ce projet avec le Nigeria, le Kenya, l'Éthiopie, l'Inde et le Pakistan J'espère que je n'ai pas fait d'omission. Et c'est un pays où nous avons globalement beaucoup de résistance en termes d'utilisation de la planification familiale. En effet, quand vous regardez les indicateurs de planification familiale entre 2019 et 2023, le taux de prévalence contraceptive est resté quasi stationnaire. On est passé de 26,3% en 2017 à 25,6% en 2023. Voilà, donc on n'a quasiment pas bougé avec des fluctuations en 2019 de 26,5%. Et malgré les nombreuses stratégies à haut impact qui sont reconnues à haut impact qui ont été développées, je veux parler par exemple de l'intégration de la planification familiale du postpartum associée à la santé de la mère, du nouveau-né et infantile et à la nutrition. Je veux parler de la planification familiale qui est appliquée au niveau communautaire, de l'auto-soin, qui est l'auto-utilisation par les bénéficiaires de la planification familiale, surtout en sous-cutané, particulièrement le DMPA. Je veux parler également du renforcement des capacités sur la technologie contraceptive et la gestion des rumeurs, de l'offre de planification familiale dans le secteur privé, qui est toujours en cours de processus parce qu'il y a des aspects juridiques et légaux qu'il faut pouvoir traverser, surtout pour les formes injectables. Je veux parler du développement d'argumentaires religieux. Bref, c'est pour dire que également au Sénégal, on a des disparités entre les régions. Il y a des régions qui ont des taux qui sont bons, il y a d'autres qui ont des taux qui sont très faibles. Et c'est un pays qui a pris des engagements internationaux en matière de planification familiale et qui est loin de son objectif qui s'est fixé. Le Sénégal s'est fixé un objectif de 46% d'ici 2030, alors que nous sommes à 25,6%. Et depuis presque un an, ou disons 5 ans, nous avons gagné que 0,01 point. Donc, vous comprenez que le défi, il est grand. En nous appuyant sur la recherche, nous pensons pouvoir disposer de données probantes pour mieux comprendre nos problèmes en matière de planification familiale, mais également orienter la prise de décision en sortant des sentiers battus. Et pour nous sortir des sentiers battus, c'est par exemple utiliser la segmentation pathways, parce que c'est ça le but, c'est de pouvoir rentrer dans des cadres qui nous permettent, à travers la recherche, de s'assurer qu'on a de nouvelles données, des données qui nous permettent de comprendre justement pourquoi on l'utilise, pourquoi certaines femmes l'utilisent, pourquoi d'autres ne l'utilisent pas, et dans quelle mesure on peut amener celles qui sont réellement dans le besoin à les utiliser de façon régulière et à augmenter les performances de ce domaine-là. Donc, en nous appuyant sur la recherche, bien entendu, sur la segmentation de pathways au Sénégal, ça nous permet de savoir comment les phares sont répartis. Les phares, ce sont les femmes en âge de reproduction, comment elles sont réparties en fonction de leur vulnérabilité. Et ça, ce qui en découle comme conséquence, c'est de pouvoir prioriser les territoires, les différentes zones du Sénégal en termes de ciblage, de la planification familiale, de mieux planifier nos activités en tenant compte de là où on peut avoir plus de résultats avec peut-être moins d'efforts et là où on peut avoir peut-être moins de résultats avec plus d'efforts. Donc, c'est juste faire des ajustements à ce niveau-là. Ça permet également de rationaliser les ressources financières. C'est important parce que dans le contexte actuel dans lequel nous sommes, on sait que les ressources se font très rares et quand on a peu de ressources, il faut savoir bien les orienter pour avoir les meilleurs résultats possibles. Et à travers Pathways, on sait qu'en intervenant sur un segment donné, on peut avoir plus de résultats. Donc, au lieu de mettre des stratégies d'emblée à l'échelle, c'est de pouvoir dire qu'on va intervenir à tel niveau plutôt qu'à un autre. Et là, les autres ressources, les redistribuer ailleurs. Donc, cette segmentation nous a également montré des possibilités méthodologiques pour affiner nos compréhensions des cibles. Donc, derrière, au lieu d'utiliser un ou deux facteurs, on a utilisé plusieurs facteurs. Et en utilisant ces facteurs, ça nous a permis de comprendre aussi que au lieu de se limiter juste sur des méthodes qualitatives et quantitatives, il y a d'autres stratégies qui sont possibles. C'est particulièrement les sciences comportementales, comme l'a si bien présenté Mariam tout à l'heure. Et ce travail, à travers cette segmentation, soulève également des défis, surtout celui de l'utilisation efficace des données de recherche. Et ça, c'est général pour toutes les autres recherches que nous avons menées. C'est justement, quand on produit des données, de pouvoir les utiliser efficacement dans les différentes stratégies et à tous les niveaux de la pyramide sanitaire. Et dans ça, je pense que à travers le travail qu'on a eu à faire, il y a eu un besoin de transfert de compétences pour être autonome, parce que c'est un projet, il finit, et quand il finit, il faut pouvoir poursuivre. Il y a également là le défi de la souplesse de l'actualisation des données de base. Quand on faisait ce travail, on a utilisé les données de 2019 et un temps, il y a eu une enquête démographique et sanitaire en 2023. Il y a une qui est très imminente qu'on est en train de préparer en 2026. Et il faut pouvoir chaque fois actualiser ces données et les utiliser. Il y a le défi d'appropriation de la segmentation et des solutions qui en découlent. J'ai presque fini. Mariam l'a dit, il y a eu plusieurs solutions. Certaines solutions sont apparemment intéressantes, mais déjà appliquées. Peut-être pas suffisamment bien appliquées. Et il y a d'autres solutions qui n'étaient pas appliquées. Ce sont ces solutions-là qu'elle vous a présentées. Il y a également ce dernier défi-là d'optimiser les solutions qui sont déjà mises en œuvre. Je viens d'en parler. Donc, il y a des choses qu'on fait. Peut-être on les fait, mais on ne les fait pas très, très bien. Et à travers cette segmentation, on peut voir réellement comment l'optimiser pour avoir les meilleurs résultats possibles. Je ne vais pas être plus long que ça, parce que je parle en français, je sais que c'est difficile pour certains. Je vais m'en arrêter là et je tiens vraiment à vous remercier pour tous les efforts que vous avez eu à faire jusque-là et de nous avoir impliqués dans tout ce processus. Pour nous, c'est en même temps une école, ça nous permet d'apprendre de nouvelles choses, mais ça nous permet aussi d'améliorer nos performances. Merci.
Thank you so much, Dr. Booya. Really appreciate your very rich comments. For the sake of time, I'm going to go ahead and briefly introduce our final speaker. Last but not least is Dr. Jambi Njuguna. She's an accomplished medical doctor and public health specialist with over 15 years of experience designing and implementing sexual and reproductive health and HIV programs across sub-Saharan Africa. She currently serves as the Chief Programs Officer at TICO, where she is the Principal Investigator for the Pathways Project. Dr. Njuguna, take it away.
Thank you so much, and thank you, everyone. I know we are coming to the tail end of the call, but I'm pleased to present some of what we are doing with the Pathways work in Kenya, where we are thinking about rethinking vulnerability for more precise programming for girls. Next. I think I can skip this part and go to the next slide and go straight to introducing TICO and why we do what we are doing. So for those of you who may not know us, we are an organization that's African-based, and we work across 6 African countries to support girls 15 to 24-year-old to deal with the triple threat in their lives. And by triple threat, I mean HIV, unintended pregnancy, and sexual violence. We do this through a community outreach approach where we use peer mobilizers to direct girls via a tech-enabled platform to girl-friendly services that are free for use for the girls in public and private sector. Last year, we impacted about 1.227 million girls across all 6 countries, majority of whom were in Kenya. So this piece of work that I'm going to tell you about is focused in Kenya, where we use Pathways to combine evidence, segmentation insights, and program design to help us better target services for these girls. And this diagram there highlights how we did it in brief. Basically, we thought about identifying the problem, prioritizing the segments, designing, and then learning and measuring. When I say identifying, we needed to first understand what are the vulnerabilities of the adolescent girls and young women that we are serving. So we did a scoping review. We looked at key informant interviews with government and other stakeholders who work with adolescent girls and young women. We also did qualitative interviews, both in focus group discussions and one-on-one with girls. And then we looked at the user journeys. How are these girls' journeys looking like when it comes to service and it comes to their lives? And that helped us identify the types of vulnerability that impact them. Then the second part is prioritization. Using the information that we got during that identification process, we're able to come up with a typing tool, and we applied it within the girls or the population of girls that we reach within Kenya to understand their context and understand what kind of vulnerabilities that they have. And from that, we were able to prioritize certain segments. So in total, there were 10 segments, but we prioritized 5 that we thought fit the profile of a girl who is most vulnerable to HIV, unintended pregnancy, and sexual violence. And then the third part now we came to design, where we designed an intervention to better able to address the vulnerabilities of this girl. And the intervention, we are calling it a cash transfer plus intervention. This intervention is actually co-created with all those people that we were with in identification. So we co-created it with stakeholders, with the girls, to make sure that we're able to align the intervention with the actual needs and vulnerabilities of the girls that we serve. And finally is the last part, which is a test and learn, which we are here currently about to embark on, where we'll implement that intervention and then monitor and learn from it. Next slide. So what got us started on this is rethinking vulnerability. A lot of people tend to assume that girls are the same, but we know that AGYW are not exactly the same. And to the greatest extent, they don't experience vulnerability in the same way. Vulnerabilities in these young women and adolescents differ. They often co-occur, they stack up, and they reinforce each other in distinct ways. And so what that means is that traditional programming for adolescent girls and young women is not going to work, because, or it may not work as effectively as if we really consider the different vulnerabilities that are affecting it, because it misses this vulnerability cluster. These layered vulnerabilities really do shape distinct pathways into the triple threat that I talked about, because they heighten the risk of acquiring HIV, they heighten the risk of unintended pregnancy, and also sexual violence. Next. So when we did our segmentation insights, what did we find? True, we found that these vulnerabilities were multiple. There were economic constraints, education disruption, there was limited agency and decision-making in this age group, exposure to sexual and reproductive health risk, and even information gaps, because not all girls were aware of certain things in their life. We also identified that these vulnerabilities were not random. They presented as patterns and were not isolated risk. And they did shape the exposure, agency, and care-seeking behavior of the girls. Next. We added on the qualitative components, and truly, we got a lot of insights. It revealed how these vulnerabilities really unfold through disruption, compounding pressures, and missed support. They really intensify key disruption points. The risks tend to compound themselves. And it also highlighted how timely support or lack thereof really shape the trajectory of a girl's life. And what this showed us is that poor outcomes in girls' lives are really not because of poor motivation. It's not always that the girl is not motivated to stay pregnancy-free or HIV-free. It's really often an outcome of blocked systems. So what the segmentation work that we did collaboratively showed us is we have multiple things that we really need to look at. And there we have a quote by a girl who shows how those vulnerabilities stack up, where the mother was in a tough financial spot, the girl got pregnant, dropped out of school. So it's a whole compounding risk sort of situation. And I'll go on to the next slide, which will show this even more. I'm going to show you a journey of one of the girls called Mwende, not her real name, of course, and how the vulnerabilities and trajectory of her life can change either positively or negatively based on interventions done in her journey map. So Mwende comes from a family that faces economic hardship. There's household financial strain. They can't really feed themselves very well. She is in school, but school fees sometimes is a problem. And when she got to class 8, which is grade 8, which is around 14, 15 years old, Mwende got pregnant. What that means is that her educational pathway was disrupted. She had to drop out of school. And this shifted her life trajectory because that puts her on a pathway of opportunity loss. So now Mwende has to deal with young motherhood and caring for a baby in the constraint of a financial, in the setting of a financially constrained home already, where she has to think about diapers, soap, and even caregiving for this child, yet she herself is a child, which really highlights the compounding pressure of both the economic and the care burden. But then down the line, Mwende finds an organization and some of her family who are really supportive of her going back to school. And there's a re-engagement program that supports her to go back to school after delivery. And this gives her an opportunity of going into the education pathway again. And her family is supportive because she can leave her baby with her mom. And so this is really great for Mwende. But remember, Mwende is still living in an environment which is financially constrained. She's still home. Her family is still struggling to feed themselves. So she's back in school, but she still faces persistent structural barriers that put a stress on her resilience and really highlight how the vulnerability doesn't go away. It just stacks and shifts throughout the life course of this girl. Next slide. So that really got us thinking and shifted our brains away from what is the outcome. So it's important that we do address the teen pregnancy, the risk of HIV, school dropout, and sexual violence, of course. And often a lot of programming has been traditional, where we do an intervention to one size fits all in a lot of programs that are there and continue to exist, and they are good. But we need to stop thinking of just the outcome and begin to start thinking of what pathway produces it. And using the pathway segmentation exercise that we were doing together with Sonda, we discovered that, like a lot of these outcomes could be a pathway through economic shock, school disruption, feeling that they're not having enough agency to make decisions, relational pressures from peers and others in their life. And they compound it such that, just having the traditional one size fits all is not enough. And so we needed to start thinking about precision targeting and tailored pathways for these girls that we are impacting. Next slide. So what did pathways exactly help us identify? In the exercise that we did, we had several key vulnerabilities that I had mentioned before. Already, TICO was giving services to girls, making sure that they're able to take care of their SRH needs. But pathways revealed certain underlying vulnerabilities like economic constraints. Even though we were removing the cost constraint for accessing services within a health system, the girls going back home may face additional pressures when it comes to their economic situation. And so we designed a cash transfer plus program where we will be having a transfer of about 2,000 shillings for the girls that we are reaching, which is about maybe $15 US. And so the girls will be able to address some of those economic constraints within their lives. When it comes to agency and decision making, we identified and we crafted an intervention which will help girls to think about what goals do they want to set, how do they want to plan for their lives. We also designed the intervention to include financial literacy, where we'll teach them or give them tips to use the money that we will be giving to them. Of course, we already have SRH access, as I had mentioned before, and we do give support to the girls through peer outreach mobilizers, but we want to be more intentional so that we are able to have more relational support. And through this intervention, we prioritize peer mentorship, where we'll be having TICO clubs for the girls together, that they can receive information that is factual, that is trusted, and they can work together with their peer mentor to be able to guide them through the pathway into better opportunities for their lives. So what the pathways revealed was the vulnerabilities, and what TICO co-designed together with the girls and other stakeholders, prioritizing segments of girls that we do reach out, who we know are at increased risk of the triple threat, is this tailored intervention, which we're calling the Cash Plus design. So really, Pathways has helped us shift from broader programming to more precision support pathways for the girls that we meet. And next slide. And this has broader implications. I've mentioned this before. So now we are moving away from a more standardized package to a more tailored and layered approach. So the girls will still be able to receive all the support that TICO has traditionally given, but tweaked in such a way that it really addresses the vulnerabilities that puts them in that pathway and helps them to think about how to support themselves to come out better at the end of it all. So next slide. I want to pause here. So this gives you a whole roadmap of where we are. We have conducted and completed our exploratory and formative research space that I talked about earlier. We have just completed our segmentation phase where we have segmented and recruited girls into our segments because we want to test out this intervention. We have identified specific girls within 2 counties of the 16 counties that we work with in Kenya. And we will be doing this intervention. I failed to mention that in my previous slide. The intervention that we've crafted, we are going to be implementing in 2 of 16 counties in Kenya. And we've just finished in April recruiting girls into that intervention. And we will start off with our cash transfer plus intervention in June this year. And we hope that down the line, we'll be able to give you more detail of how that went, what kind of autonomous decision girls were able to make based on their individual life skills, and also what kind of agency and agency support they required to help them do so. And so that's the part we are in, where we'll be doing the intervention and measuring it for learning, so that we can see how we can iterate and scale it up within the whole organization. Thank you so much.
Thank you so much, Dr. Jambi. Excellent presentation from everyone. I know we've run over, but this has been just such a rich webinar, and I'm pleased to see a lot of people are still on the line. We do have a barcode here at the bottom to give feedback on the session. But before we close, I want to again express my gratitude to all of our presenters. And just note that we have a lot of conversation going on in the chat, and some really excellent questions. Some of them have been responded to. I'm going to take these questions and hold on to them, and we will look for ways to circulate some responses to this, to continue engagement with our community, so that we can answer these questions and even more questions that are coming up. I'm very sorry for our technical difficulties at the beginning of the call that delayed our start. But I think we just had such an incredibly rich panel of presenters. So I will move to close the call since we are running a little bit over. If you want to stay on the line and have a conversation, we can certainly do that. But if you need to drop, we totally respect your time. Maybe I can ask our presenters to stay on for just another few more minutes in case anyone wants to come off mute and just, pose their question.
Amanda, there was a good question. I thought maybe we can just reread it about barriers to scaling. And if any of our presenters want to talk about any of the challenges beyond funding, I think was more other policies or engagement. And Samson responded, but if any of the other presenters want to respond, I think that would be really interesting to hear from.
Yeah.
I don't know if Jambi or Miriam have any thoughts.
Yeah.
Dr. Dio.
I didn't get a question again.
Oh, sorry. The question was, what are the barriers that you're seeing in terms of scaling beyond funding? Do you have to engage with specific stakeholders? Are there policies or political will? Are there any other challenges that you've?
Oh, the most critical barrier is in terms of the human resources, having the right human resources, in the facilities, to be able to provide the quality of care that is needed. So, most part of the world is where we have a lot of migration for the health workers across. the border. So human resources is one most critical thing, Then, of course, the deep sociocultural barrier that irrespective of whatever you do, you barely will be able to disengage them from that their forefathers believe. So this it's something that is also a serious. Then, of course, every day we continue to improve on the quality of data. So having quality data is also critical to making empirical, decisions. So all of these are things that I can say, critical barriers, that limit, scaling, putting things to scale. But in terms, of course, for our country, we are quite lucky to have a political will. But so sometimes you want to scale up, but if there's no political will, you just definitely cannot do anything. So we have a president that's passionate about crashing maternal mortality. We have a coordinating minister who is providing leadership. But for other places, it might not be like that. So you might be having issues, trying to navigate, that to be able to scale up whatever you're doing. I think those are things that quickly we mentioned. I think somebody also was trying to ask around how do I track the deliveries that happens in the community. One thing that is important is that when those deliveries happen, they all know they must have them vaccinated. So when they bring them to the facility, we then get them registered and then keep tab on them, to have all their full immunization complement. And then ensure. But like to avert this kind of community delivery is why we engage the community-based health workers who line list every woman, and so even if she delivers elsewhere, but she has been line listed and captured, we'll be able to track and say, you were supposed to deliver as so dates by your birth plan, but we haven't seen you. Oh, you say you have delivered, then we can then keep tab on them. So that's a quick answer to that. Thank you.
Thank you so much, Dr. Dio. Dr. Jambi, I know you have to drop in about a minute, but there is a question in the chat for you if you have a moment to respond. Oh, I see you just responded. Sorry. In the
Yes,
chat.
yes. I was hurrying up to finish up before I have to drop. But thank you so much for inviting us, and this was really nice.
Wonderful. All right. Well, thanks everyone for staying a little bit longer and your support of Pathways and championing Pathways. And we look forward to continue to virtually engage with everyone. Have a great rest of your weeks and weekend.
Thank you. Bye.
Well, thank you so much. Bye.
Thank you.